session. I think we are on. Yep. Okay, we are going to deal on controversies in neuro-ophthalmology, and this is a point-counterpoint session. We are going to come into the common clinical conditions which we encounter in our day-to-day practice. We are going to deal with 3 clinical situations, and I think it's going to be opening batsman is Dr. Durga, my colleague. She's going to talk on, do we need to investigate optic neuritis routinely? She's going to talk, yes.
A very good evening, everybody. Thank you, ma'am, for including me in this IC. So my talk for today is, I'm going to talk for, yes, we are going to investigate optic neuritis routinely. So optic neuritis is an inflammatory disorder of the optic nerve, and the most common cause can be multiple sclerosis as per the Western literature. But we all know that optic neuritis in Asian population has been reported to be atypical, unlike the Western population. And the understanding of optic neuritis is rapidly changing with the discovery of the new seromarkers, development of latest investigations, and the updated diagnostic criteria. So let me start with a simple, straightforward case. A 30-year-old male came to us with a sudden, painful drop in vision for the past 4 days. His vision in the right eye was 6/6, left eye was counting fingers close to face, pupils had RAPD in the left eye, color vision was impaired in the left eye. And this is a fundus picture, this picture that you're seeing. Right eye had disc edema, left eye was normal looking, maybe a crowded disc. Fundus was normal otherwise. The right eye fields was relatively normal. Few peripheral defects, could be learning curve. The left eye was completely washed out. So the probable diagnosis is straightforward left eye optic neuritis. So do we investigate? Yes, I would prefer to investigate. Why? You see here, the patient is a male and he had a profound loss of vision in the left eye. There is a disc edema. So I would put this as an atypical category. It was an acute optic neuritis, but atypical. An MRI was done which showed optic nerve enhancement with a perineural enhancement too, and signal in the nerve was seen. And we did all the blood workup, NMO, MOG, granulomatous workup, autoimmune workup, and he turned out to be MOG positive. It was a MOGAD disease. So let's see some of the epidemiology of optic neuritis pertaining to our population. So previously in 1980s, we had a study stating that MS constitutes 0.3 to 1.5% of prevalence. That is 1.33 per 100,000 population only. And the recent studies conducted by the demyelinating registry at Mangalore told, that was in 2014, they had told the prevalence of MS was 8.3 per 100,000. And for NMO, it was 2.6 per 100,000. A substantial number of cases from this part of the world. Even in 1980s and now, it has been most of the atypical presentation. And from the same center, that is the Mangalore Center, they had another presentation saying that NMO-ST represent 20% of all the demyelinating disorders in South India, and out of which 30% were aquaporin positive and 20% were MOG positive, and remaining almost 49% were seronegative, that is both negative for MOG and NMO. And this is one of our publication from our institution where we found that almost 20% were MOG positive and close to 10% were NMO positive, and more than half of the cohort, that is close to 56% were seronegative, and the prevalence of MS was noted to be only 5%. So let's see, what is it? First, the typical, and we have to differentiate whether it's a typical and atypical optic neuritis. Typical could be a CIS, that is clinically isolated syndrome, or MS presentation, presenting as a typical neuritis. And we see that if the patient is young, female, unilateral, associated painful vision drop, subacute onset of vision drop, and retrobulbar presentation comes under typical optic neuritis. But it's totally the extremes of age, the profound patient presenting with profound vision loss, painless attacks, and bilateral involvement with severe disc swelling goes under the atypical category. And there are numerous causes for atypical neuritis. So initially we considered that NMOSD was just a variant of MS, but now it's designated as a separate entity, and though they have some phenotypic overlap. So here's a chart which says what are the different clinical features of MS and MS optic neuritis, aquaporin and MOG optic neuritis. The age group is slightly older in aquaporin and MOG, and we see that there is almost equal, there is no sex predilection in the MOG category, and painful attacks are seen mostly in MS and MOG, whereas painless are seen in aquaporin. Bilateral involvement is more common in the atypical groups, that is aquaporin and MOG, and vision is usually severe in aquaporin and MOG, and recurrence is noted more commonly in aquaporin and MOG diseases. And we see that the recovery is poor in NMO spectrum disorders, especially the aquaporin positive, and steroid dependency is more common in MOGAD. Visual outcome is poor in NMO spectrum. And the other association, literature says that ADEM is strongly associated with MOGAD, and area postrema or transverse myelitis are usually associated with aquaporin diseases. In the MRI, we see that the MS optic neuritis is typically short optic nerve involvement, whereas aquaporin is usually a long segment involvement, and in MOG, they have the classical perineural enhancement. CAs of oligoclonal bands are seen in MS optic neuritis. They can be seen. So next entity is the autoimmune conditions where we need evaluation. The causes could be Sjogren's, Charcot's, SLE, or even antiphospholipid syndrome. And we see that optic nerve involvement could be immune mediated or due to vasculitis leading to ischemia of the nerve. So the main thing is, like, they can be manifestation of NMO spectrum disorder. So always remember, when you're suspecting autoimmune cause for optic neuritis, include an NMO antibody also in their workup. And next entity that I would like to say is the infectious optic neuropathy, especially in country like India. There are various viral or bacterial infection which can present as optic neuritis. The most common being syphilis, TB, or even HIV. So look for history of any preceding fever, exposure to infective organism, or any travel to endemic countries or endemic areas, and other clinical features like associated meningitis, encephalitis, meningoencephalitis, or ocular intraocular inflammation like vitritis, retinitis. Then these patients require extensive laboratory investigation, including a CSF analysis to confirm the diagnosis. So the approach for optic neuritis in this era of biomarkers, I've taken it from an article by Professor Johnson. Like, he says, MRI brain on orbit is mandatory for all patients presenting with optic neuritis, and always test for aquaporin and MOG in patients with atypical neuritis, and consider aquaporin for any optic neuritis unless it's a classic MS on MRI and a mild vision loss. And do infectious and inflammatory diagnostic workup for patients with atypical features and associated systemic abnormalities. So let me finish with an interesting case. A 23-year-old male came with the right eye followed by left eye diminution of vision within a span of 3 days. It was painless in the past 1 month. There was no other history of any numbness, weakness, fever, and he's a teetotaler. There was no chronic medications. Family history was unremarkable. Systemically, he was fine. He had received IV steroids for 3 days followed by oral steroids, and he was on oral steroid 40 milligram when he had presented to us. And the vision on presentation was 3/60 and 24 in both the eyes. Pupils were sluggish. Color vision was impaired in both the eyes. Slit lamp and adnexa was normal. And this is a dispatcher which showed mild pallor in both the eyes. And the fields in the right eye was central and some few scattered defects, non-specific pattern. The left eye was constricted. And this is the MRI image of the patient. Patient had an intraorbital, orbital apex, and the chiasmal nerve thickening and signal in the nerve. So which we suspected optic neuritis, bilateral involvement. So he underwent all the blood workup. ESR was negative, NMO, MOG was negative. All the autoimmune, the granulomatous were all negative. CSF analysis showed some pleocytosis, but the glucose proteins, MTB, were all negative. So the provisional diagnosis was atypical neuritis, long segment involvement, bilateral with a bilateral vision loss and a poor recovery post-steroids. It was a seronegative. I suspected a seronegative NMO spectrum disorder. But the clinical profile, young patient, adolescent male with a sequential vision loss, prompted to think of LHON. So we advised him to complete the genetic testing also. Unfortunately, he was positive for LHON. For 11778 was positive. So it was a case of bilateral optic neuropathy secondary to LHON. So I would like to say that the literature evidence shows that features of optic neuritis in Western studies cannot apply to patients with Asian population, and we ophthalmologists should be aware of various presentations of the condition to provide an accurate diagnosis and appropriate management. So optic neuritis in our population needs detailed investigations routinely. Thank you.
Thank you. Thank you, Dr. Durga. I think we will have the next speaker also, and then we will come to a conclusion remark regarding that particular entity. So we are going to have Dr. Mahesh, who is going to speak on, do we need to investigate optic neuritis routinely? He's going to talk for no. People who heard him speak in Hall 7, just forget it.
Okay, so First, I would like to thank Dr. Ambika for having invited me in this instruction course. So, my argument will be, I'm little changing the topic. Every case of optic neuritis should be investigated, imaged and evaluated. No. So, I will explain each one. I would like to thank Dr. Durga Priyadashini for giving an overview of optic neuritis, and she has made my work simple. She has told which are the atypical features, she has told clearly, and I'll be building on what she has told. So my focus will be, not every case needs a workup. Focus is on every case. Extensive workup, that is the next statement I would like to make. I am not contesting the fact that, I'm not telling that extensive workup needs to be done for lengthy blood workup, LP, and I am not contesting the fact that every case needs a contrast MRI brain and orbits in the case of optic neuritis. There is no doubt about that. But what I will be contesting is every case don't need this workup, and every case does not need an extensive workup like a lengthy blood work, like all the extensive tests Dr. Durga has beautifully brought out in the appropriate situations, and a lumbar puncture need not be done in every case. So in order to evaluate these patients, we need to know the natural history of this optic neuritis, which has been appropriately told by Dr. Durga. So typical optic neuritis, majority of the patients recover, as been told by the optic neuritis treatment trial, and it has also found that blood investigations are not very helpful. Then all the blood workup required according to the ONTT study is only relevant to the steroid use like blood sugars and not extensive workup. There are very clear clinical features of atypical optic neuritis, as has been told before. It has to be recurrent, it has to be steroid responsive, or it is steroid dependent, or it is bilateral. And these are the clear defining clinical features of a atypical optic neuritis. And once we see these patients clinically, we take the history itself, we have a fair idea of whether this is going to be a atypical or a typical optic neuritis, and we can always tailor our investigations based on our clinical examination and history. Also, not only clinical, we also have clear radiological findings with respect to atypical optic neuritis. As seen in this picture, it has got a bilateral extensive optic nerve involvement. More than 50% of the optic nerve length has been involved in both the eyes. Here also there has been extensive optic nerve involvement here. More posterior involvement of the optic nerve as seen radiologically. Again points on atypical presentation, or a longitudinal extensive spinal cord involvement. So once we see all these radiological findings, in addition to the clinical findings, we know that whether this needs really a extensive workup or not. So we need not do it for every case. So there was one Indian study which was done in 2014, where they studied 99 eyes of 83 patients for a period of 3 years. And they did all these blood investigations, and they found it to be normal in the majority of the patients. And they found recurrence to be only 16% of the cases were recurrent. And majority of the patients recovered with a reasonably good visual acuity. There's another Indian study. I'll be quoting the same study which Dr. Durga has told, and we have seen that majority of the patients do not fall under the, almost half the patients are typical optic neuritis. So less than half only falls under atypical optic neuritis, and majority of the, out of those 50%, 21% did not progress at all, and it was monophasic as per their study. So based on all our Indian studies, we can fairly evolve an algorithm. We need to do a contrast enhanced MRI, and if there is poor visual recovery, then we can go for testing for NMO, IgG. If not, and not in every case. And if there is recurrent, again we can do a repeat testing for NMO and do a repeat MRI brain of the spinal cord and the brain, and with that we can decide whether these patients will require more extensive blood testing. So in conclusion, for us to decide whether all these patients need, we need to see the relevance of these investigations in every case. Each and every case is separate. We need to see them case by case. And we also need to remember that In our country, we need to have resource utilization, time utilization optimized, and also we need to factor in the cost for our under-resourced population. Thank you.
Thank you, Dr. Mahesh. And I think we can just summarize this topic. And if it is a typical optic neuritis, probably you can just watch the patient with the routine ONTT protocol and you can treat it. But if it is atypical, any of these findings, but if the same patient first attacked bilateral event with an atypical features, you have to escalate the blood investigation, CSF, and the imaging. As simple, you need at least an MRI. Is preferably better to get for an MRI, and there's no role of CT in optic neuritis. So that is a very important point which you have to consider. And if at all a patient has an atypical optic neuritis features, you have to get all the atypical workup. And if a patient has a prior history of any fever or any exposure to one infection, he needs an extensive infective workup panel also. That's what I would consensus. And maybe seromarkers are going up in the literature, so we need that also to be added in most of our optic neuritis workups. So we will move on to the next topic. We are going to talk on, is MRI for all cranial nerve palsies is required? Dr. Rashmin Gandhi is going to speak as yes.
Thank you, Ambika. Thank you for this very kind invitation. And even bigger thank you that you've chosen my adversary who has always been, or we have been always on the same side for last many, many years. He has been friend, philosopher, and guide. So today is a chance for me to compete, maybe try to compete with him. But I know that as a president and vice president of INOS, you probably have done some technical glitch here, because I'm not able to get my presentation there. All right, so Mahesh has been, and Durga, have been very diplomatic. They said that, you have to do the investigation that we are discussing in few cases. You have to look at few things. You don't have to look at few things and then work for investigation. My job is going to be, I'm going to say that every single cranial nerve palsy that you see requires MRI scan. And I'm trying to argue in that way without any ambiguity. And we'll see whether you're getting convinced or not. Yeah. So actually there is no debate. To me, I feel that there are cases where there is no question that you require neuroimaging. Let me give you an example of this. He is a 65-year-old male with vasculopathic risk factors, a clear case of third nerve palsy. But when you look at his pupil, you know that he has anisocoria. So there is no debate in this case that this patient requires neuroimaging. Everybody agrees there. Very good. Now this is the second case. A third nerve palsy who recovered, has a ptosis of the left side. Recovery took place after 5 weeks. And you see on the left, you see there is a widening of pulpal fissure. And when a patient looks down, there will be a lid lag. These are signs of aberrant regeneration, a clear-cut indication for neuroimaging. All right, so you are convinced that third nerve palsy, those examples, you'll do neuroimaging. One more example, patient who had a diplopia. He was told that his problem, this abduction limitation of left side, is related to his uncontrolled diabetes. But when you see his ocular motility, you see that even adduction is limited. So that means when you have multiple cranial nerve palsy, you have to neuroimage, no debate there. Another patient, 29-year-old male, type 1 diabetes, has been having diplopia for the last few weeks. And you see, patient looks to the left, everything fine. Patient looks to the right, and there is an abduction limitation of the right side. Again, no debate in this patient, though patient has vasculopathic risk factor, that you have to do MRI because of the study that Ambika, me and others did, which was called SNAP study, was published in 2014, where we concluded, and there are other studies which corroborated us, saying anybody who is less than the age of 50, irrespective of what they have, should undergo MRI scan. So in other words, debate whether MRI is required for cranial palsy is limited to very small number of scenarios like this. You say that, okay, 70-year-old male, known patient of hypertension, diabetes and whatnot, and presents to you like this. He has a complete ptosis. And you see there is an abduction, the eye is exotropic, and when you look at the oculomotility, you'll find that patient has a complete third nerve palsy, but the pupil is not involved. So this is the scenario where you'll say, oh, 70-year-old male, vasculopathic risk factors, pupil not involved. Why don't we just wait? Because that's what the literature says, that we don't really need to do anything for these patients. However, let me run you through some of the case reports. This is the case report which was published in 2020 in Neurology, where they said pupil sparing oculomotor nerve palsy with posterior communicating artery aneurysm. It was not just one-off. This was done, there is another case report of a 56-year-old man who had a fluctuating diplopia, was diagnosed as having third nerve palsy without involvement of pupil, and was asked to observe. A few days after the diagnosis, he suffered from subarachnoid hemorrhage, secondary to aneurysm. So what it tells you is that initial period, the pupil was not involved. Now my honorable adversary, who has taught me as well, would tell you that 14% of the patients of third nerve palsy would not have pupillar involvement on presentation. So only thing you can do with these patients is just observe, call the patient back, why to undergo all this MRI and all that. But then I would say that 2008, this was from Nicholas Welpe's group, pupillary sparing and aberrant regeneration in a chronic third nerve palsy. Patient had a third nerve palsy for a few months, never had a pupillar involvement, but had posterior communicating artery aneurysm. So what you are saying here is that there is a high possibility that even if patient has a third nerve palsy, pupil not involved, he still can be harboring aneurysm, which can be fatal. So that's about the third nerve palsy. What about this patient, which I saw when I was at SN? Patient, vasculopathic risk factors, old age, and has a 6th nerve palsy. Now there is an abduction limitation of the left side, which is very clear. It's an isolated 6th nerve palsy. Again, we will say why to neuroimage, because these patients are likely to be secondary to ischemia. All right. Here is a case report in 2021, a series in fact, where they studied isolated 6th nerve palsy, and their conclusion was isolated 6th nerve palsy can be a first presentation of nasopharyngeal carcinoma. They followed up 66 patients, they did a retrospective analysis. And what they concluded, they said that even in patients aged more than 50 years of age, with microvascular risk factors, they all, and isolated 6th nerve palsy, they had a nasopharyngeal carcinoma, which they were harboring. Another series by Valerie Buse, Madhura Tamankar, Prem Subramanian et al., they did even larger case study, and what they concluded brain MRI and laboratory work have a role in the initial evaluation, even in the older patient with isolated acute motor neuron palsy, because in their series they found that these patients, old patient, motor neuron palsy, vasculopathic risk factors, they were still harboring something sinister in their brain. One more series by Steve Galeta's group, again they said that acute oculomotor neuropathies, they did a prospective study, and they concluded that neuroimaging as a primary modality of investigation has a role, because you are likely to miss out sinister stuff. So obviously then the question will come up, no, but we don't have MRI availability, what about cost, logistics, patient will not pay. My question would be, if patient is willing to pay, MRI is available, and the cost is not an issue, would you shy away from, with this knowledge that he can be harboring something which you cannot detect clinically, would you not go ahead and neuroimage? Now, if you say cost is an issue, well, tsunami is a once in a lifetime event, and it's extremely rare on Indian Ocean, right? But after that 2004 event, we have a complete system of tsunami warning, and at the slightest of earthquake, the whole system is activated, though it costs a lot. Why? Because what you are missing out can be really fatal. So I rest my case, ladies and gentlemen.
Thank you, Rashmin. That was a wonderful talk, and we'll see whether your friend is going to agree to that or not. He's going to talk that no, he's not going to image on all cranial nerve palsies. Okay, well, these two guys going to fight each other. I'm going to rest my case with Dr. Mahesh for the conclusion and not me.
Good afternoon. Thank you, Ambika, for having me. If we haven't got all your popcorn ready, this is the time for popcorn, basically. Talking of tsunamis. Okay, so tsunami is once in a lifetime event. It is serious. Lots of people died. And then you have a tsunami warning system, which also tells you that many earthquakes and many substratific things happen on every other day. It doesn't mean you evacuate everyone and clear everyone from the Andaman Islands. So, do we do MRI for all cranial nerve palsies? I am supposed to talk on no, and my short answer is no. I have some assumptions because the true answer to this highly entertaining session lies not in yes or no, it lies somewhere in between. So my assumptions are, I'm going to talk on isolated because like Rashmin said, multiple cranial nerve palsies, there's no discussion about it at all. I'm talking about neuroimaging right now when a patient comes to you with say a third nerve or a sixth nerve or a fourth nerve. Would you do an imaging today, tomorrow, and review the patient? And lastly, what are you afraid of? The tsunami happens to be the aneurysm. Tumors, you will pick them up. At some point, if you follow up these patients, you will pick them up because these are not nerve palsies which would improve over time. Okay? They're definitely going to be on the downslope. I agree it is important to pick up aneurysms. If you look at this chart here, and look at point number 2, if you look at the risk of rupture and what it does to survival rates. If you look at point number 2, where there's no motor deficit due to aneurysms, but there's nothing else except a cranial nerve palsy, the survival rate for a patient is 60%, which means all of you have a role to play in picking this up early and detecting it early. Okay? So, my long answer is going to cover quickly 3, 4, and 6 and some personal thoughts along the way. So let me start with the fourth cranial nerve. The most common etiology of fourth nerve is congenital. Okay? Congenital may be present since birth, may be presenting at the age of 40 when the fusional reserve breaks down, but that's the most common. What is very interesting in this population-based study, which means it does not suffer from referral bias to a certain institution, is that there was no aneurysm in this list at all. That way, okay. Now, if you look at, so there itself, I can say that you don't need to do MRIs for all as a blanket thing for all cranial nerve palsies. If you look at acquired sixth nerve palsy, in all ages, the idiopathic was 26, but if you look at identifiable causes, you had neoplasms and malignancies right on top. Aneurysms were very rare in isolated sixth nerve palsy. So once again, would you jump and do an MRI immediately, or would you prefer to wait and see which way the nerve palsy, isolated sixth nerve, for example, in an elderly with the diabetic, it went? It's not that I'm going to say, look, you're a diabetic and you have an isolated sixth nerve palsy, you take Neurobion tablets and come and meet me after 3 months because everything will be okay by then. No. These are all things you need to follow up over time. You have to use your head a little bit as well. Okay. Thirdly, as far as acquired third nerve palsy, the most common etiology, again, in this, this is from the Mayo Group, 42% were presumed microvascular, okay? And 6% was compression from aneurysm. So there are some of your numbers. But what is interesting is, regarding pupil involvement, microvascular third nerve palsies can present with pupil involvement, and as Rashmin very presciently informed me that yes, I don't have that particular slide, this is another one. Okay, many aneurysmal third nerve palsies can present with pupil sparing. This is something you have to be very aware about. Okay, so things are not as clear cut as we learnt them maybe 30 years ago. Okay, so their criteria for imaging for say third nerve palsy, etc., has changed over time. So earlier when we studied, it was pupil sparing. It's usually ischemic. If it's pupil involved, you must do an MRI. Okay. Over time, sometime around 2000 or so, Andy Lee came up with this understanding that if you have complete third nerve muscles involved, but pupil is completely spared, there's no need to image these patients. But if you have partial sparing, partial involvement of the third nerve muscles, but even if the pupil is spared, you should scan them. So over time, this changed to yes, and over time, this has also changed to yes. So I will agree with Rashmin that if you have any patient with third nerve palsy, because the risk of aneurysm is much higher in an isolated third nerve palsy, with or without pupil sparing. So there, my answer would be yes. But Tamhanker's study, which Rashmin quoted, refers to any cranial nerve palsy and says, yes, you should scan any cranial nerve. Now, therein I have a little disagreement with that kind of suggestion. So she said 16.5, and if you remove the third nerve palsies and you remove the causes created like giant cell arthritis, which you would have picked up, this is not something which you'd see on an MRI, 4.6% was the number left for fourth nerve and sixth nerve palsies. So the question I ask you is 4.6 very high or very low for you to decide on doing an MRI right away, okay, on presentation. So this, I think, is open to interpretation. And how many of these, therefore, over a follow-up would have had an MRI anyway because of either non-improvement or worsening of the condition or some new neurological deficits which might happen, okay? So essentially, the Tamhanker paper was, we have a fear factor here that if you don't scan, you're going to miss something like an aneurysm, versus the cost factor which Rashmin had brought up. Should you do a scan for everyone? So either no or yes, and I think the answer lies here. It depends on what. What does it depend on? I think age group is important. If you're seeing a child with a third nerve or a sixth nerve palsy, you would scan these. In third nerves, it's serious. Sixth nerve could be malignancies. Okay? Whereas the fourth nerve, it could be congenital. That's the most common cause, or maybe trauma. That means. Secondly, if it's an adult third nerve, okay, yes, you would do for any pupil involvement or any partial third. So I would say yes, but sometimes what I do is, if I have a clearly ischemic, complete third nerve palsy, total pupil sparing, I may even not want to do an MRI if the patient cannot afford it, because that's a very practical situation that we have with us. You say, get an MRI. He says, I can't. What are you going to do? So it may be diabetes. That's what you think it might be. But what you can do is maybe call this patient every 3 days or every 4 days and just keep a close watch on the pupil over the next few weeks. Generally, a pupil-sparing aneurysmal third nerve palsy will turn pupil involved over 14 days or so. So it's good for practice, even if you think it's a diabetic third nerve palsy, is to follow these patients carefully until they improve. Once they start improving, it's a different situation. As far as fourth nerve is concerned, it's congenital and traumatic are the most common reasons. But yes, if you're having new symptoms developing or new neurological deficits, then obviously you need to do an MRI for these patients. As far as sixth nerve is concerned, if there are no microvascular risk factors, I would still consider doing neuroimaging, especially younger age group, not a diabetic, not a hypertensive. But if it's in the older age group with risk factors isolated, I think you can follow up these patients like you did your third nerve with complete pupil sparing. But again, close follow-up, okay? Please remember this, headaches. Someone may say headache, but if you're saying a new headache, something different, worst headache of my life, change in characteristics of the headache, or any other deficits that occur, I think it's important to consider neuroimaging, and also any cranial nerve palsy with orbital signs. In a diabetic who may have orbital, it may be mucormycosis, which is also equally life-threatening. Okay, so I think practical considerations could be availability of specialists. If you're sitting in a city with lots of neuro-ophthalmologists, good for you. You need skilled history taking. You need to pick up subtle signs of other cranial nerve involvement, whether it's pupils, and experience does matter. So the question would be, would you also do, for a general ophthalmologist, seeing a patient like this, it might still be a good idea just to scan all these patients if the patient is able to afford it. Interestingly, the cost of an MRI is important. So it costs around 3,000 rupees or so. Some centers, it may be 2 to 3 times even more. That's what they charge. My question to you is, would you therefore, at least to rule out an aneurysm, would you at least consider just doing a CT angio? Just that. That alone will do and to help you to decide this is aneurysmal or non-aneurysmal. So question is, neuroimaging on presentation in isolated cranial nerve palsies, it depends. But if you say neuroimaging on presentation for all cranial nerve palsies isolated, I would say no. This was an interesting comment I thought I'll end with. This was a paper which came out, I think, in Lancet. I think, should we replace the art of clinical acumen with the science of clinical decision rules, like an algorithm, okay? This was in response to an article called High-Risk Clinical Characteristics for subarachnoid hemorrhages, okay? So the thing he said was medical practice is increasingly based on protocols and decision tools, I agree, driven by the need to demonstrate that you're following the best evidence and also in an attempt to avoid litigation. My point is this, that we should also, however, remember that not all patients fit neatly into protocol boxes and that the best clinicians often make decisions based on their instincts, which are developed through experience. And that's why it's not called the science of medicine. You are involved. It's called the art of medicine. Thank you.
Thank you, Dr. Naveen. It was excellent. I rest with Dr. Mahesh for the conclusion remarks.
There have been excellent arguments on both the sides, and it's hard to counter both the speakers. So, in a nutshell, whenever we see an isolated cranial nerve palsy, I apply what Dr. Neil Miller has told us. He says that sixth nerve is a tumor nerve. So whenever we see a sixth nerve, we always have the fear of a tumor. So I feel it's better to do a neuroimage, MRI, all sixth nerves. I mean, other panelists may differ on my thought, but I'm scared of sixth nerve because it's a skull-based lesions can affect that and other things. As far as third nerve is concerned, we have very clear protocols and definitions, which has been appropriately told by both the speakers, and pupil involving, pupil sparing, and if it is pupil sparing, if it is complete or incomplete. If it is what generally we have seen in clinical practices, if it is complete with a documented blood sugar levels, high blood sugar levels, and if the ocular movements are completely restricted, but pupil is perfectly reacting, we always take a chance and say that we'll wait and see. We can do that. However, as per the protocols, if it is incomplete, even with pupil sparing and obviously with pupil involvement, we need to have a neuroimaging MRA and MRA. And again, with respect to fourth nerve, as has been shown by Dr. Naveen sir in his presentation in the study, which has said that aneurysms rarely affect the fourth nerve. We can always pick it up through, follow it up, because majority are congenital with a documented ischemic risk factor. However, in case of trauma, if not MRI, at least we need to do a CT for looking subarachnoid hemorrhages or anything in case of a trauma. So there again we need to play by the causative agent of the fourth nerve palsy. Above all this, I apply one principle, one affordability or not. If I get this problem, what will I do for myself? So we will defy all the clinical science, clinical protocols. If I get a sixth nerve palsy, if I get a third nerve, even with pupil sparing, I will do a neuroimaging for myself. I will do MRI for myself. And we will do the same thing for our relatives, for our close ones. So I think we can offer that to our patients also.
That's brilliant. Thank you, Dr. Mahesh.
So we now move on to refractory idiopathic intracranial hypertension. What would be your choice? Would it be optic nerve sheath fenestration or would you do an LP shunt? And to speak for ONSF, Dr. Ambika.
Okay, thank you so much. And I'm going to move on to optic nerve sheath fenestration per se, because I'm not going to restrict my talk only for refractory, because we have a lot of IIH patients presenting in chronic stage also who will require this technique. So I'm going to keep it as IIH and the role of ONSF in that aspect. So ever since Divika brought this, it was Hyre who showed that sheath fenestration will be useful for papilledema patients. And this is this area which is we are more concentrating on, immediate retrobulbar area, where there is a, I mean, it's rich in blood supply. You have to be very careful if we are planning a technique. And this is this area where we are going to decompress the optic nerve of the CSF, which is compressing the optic nerve. So by and large, the technique is we make a slit in the optic nerve sheath, or we can make a window and we decompress the optic nerve and let out the CSF fluid. That's the technique. So when do you apply this? So the mechanism of action is it's a subarachnoid scarring at the fenestration site, and it could function as an ICP gradient towards the posterior part of the optic nerve, or it's an egress theory of the fenestration or the Bernoulli's theory of fluid dynamics. So here is the indication. So I'm going to talk on the indications from an ophthalmologist perspective. I think we all are ophthalmologists. So we would do techniques which are easily in our axis, and the patients presenting to us are with predominant visual symptoms. So you have to find a patient group which has a chronic IIH, atypical IIH like cerebral venous sinus thrombosis, AV fistulas, intracranial mass, aseptic meningitis, or a sheath hematoma. These are the common indications where we do apply a sheath fenestration. The next group is the refractile IIH, where there is a progressive visual decline, visual field loss, and when they are medically not responding to the treatment, and OCT is showing a gross fluid accumulation, more than 300 thickness of an RNFL, generally they don't do that well with medical treatment. And if the opening pressure is beyond 35 millimeters of water, probably that's the case which you have to rest with a surgical technique. So this is a patient who is a 57-year-old male who came with a chronic history of drop in vision, gradually progressive over 3 years. And he's already had a shunt by his local neurologist. So when we saw the patient had a hand movements vision, in right eye was grossly down, and that of the left eye had 624 vision. And you could see there's a gross asymmetry of the disc edema. Here you are having a pale disc which is trying to settle down the edema, and then another disc which is having significant edema. So this is the visual field what you had seen, the patient had elsewhere. So there's a gross field loss, and right eye is hardly there's any central island preserved, and MRI brain did not show any atypical features. So we went ahead and performed the better eye, which had a good vision in the left eye. We proceeded with the sheath fenestration because that had maximum fluid which can come out on our sheath fenestration, but definitely it has its own demerits too. And this is the day one result of the sheath fenestration, and this is what he looked like on 2 months follow-up. So there's a definite reduction of the fluid in the fellow eye, and this is his visual acuity and follow-up, and you can see the visual field by 7 months. So that was the better eye. So this is the improvement what you get with the ONSF. So you see a visible change in the visual parameters. So this is the OCT on initial, and then there's a gross RNFL and a GCC loss. So now the question is, my friend, Dr. Guha is not going to accept that we are going to settle down with a sheath fenestration just like his Bengali friend. Now let me say that ONSF is in our hands. The patient is coming to you as an ophthalmologist with a progressive visual decline. When a patient is coming with that, no atypical features, no neurological features, and your neurologist is saying, madam, vision is coming down, please take over. So there you have a real surgical technique which can help you. Go ahead, fenestrate him. Don't wait for the neurologist to open the window for the vision. So he's going to open only the shunt. He's not going to come back. And even after shunt, this patient what I showed is post-LP shunt. So even after shunt, there are indications for sheath fenestration. So let me rest that sheath fenestration has its own benefits, but yes, it has its own cons. It's an early threat to the vision. You need a lot of clinical expertise to do the procedure, and sometimes you may need a complementing CSF diversion procedures. And there are a lot of literature articles which are supporting that, yes, it improves the vision as well as the visual field. And this is a 20-year multicentric retrospective data which showed that, yes, sheath fenestration had almost 50% of them reached a best corrected visual acuity, and more than 80% of them did recover or stabilize. And sheath fenestration in the setup of a secondary atypical IIH, that's where we have the glitch. The patient is having a transverse sinus stenosis. So here an early ONSF will improve and stabilize the vision, because once you let the patient go to the neurology wing, he's going to go into the interventional neurology guy and he's going to stent him. If they stent, he's going to put him on anticoagulants, and that's it. So once they have done it, you're not going to do the sheath fenestration that easily. So fenestrate the patient prior to a venous sinus stenting. That makes the key in secondary atypical IIH. And this is another study which showed that, yes, even in cerebral venous sinus stenting, there is a role of a ONSF. And there is, interestingly, a MORI group have come up that not only once you fenestrate, you can do secondary and tertiary fenestrations, which mean even after doing once a fenestration, there is a scope for the subsequent fenestrations. So these are the various routes how you can go, and I had shown the video. And the only advantage of a medial transconjunctival approach is it's a quick access. You don't need to have an external incision, and there is an increased operating field. But I can make one thing is there's a lot of fat prolapse, what I had experienced. So identifying the optic nerve may be really difficult in a medial conjunctival or any other approach what you would see like this superomedial or a lateral orbitotomy approaches, and it has its own complications to certain extent. If you're a good ophthalmologist and she's a very good squint surgeon, I know why she's talking for shunt. So you have very minimal complications with optic nerve sheath, but yes, there are potential complications right from retinal artery occlusion to traumatic neuropathy to significant orbital infections and squint and diplopia. As I mentioned, there are a lot of contraindications for ONSF when a patient is on anticoagulant, when there are CNS infections, when there is a mild to moderate vision loss, you can definitely manage them with the medical therapy. And if it is not indicated for headache management, and when there is no gross disc edema, maybe you have to sit and think back whether before touching that eye. And it is a safe and effective procedure. Medial transconjunctival is having a quite good access, but bilateral papilledema, it is better to fenestrate the eye